I'm Dr. Erkan Duman from Westside Hospitals. Today I will talk about the diabetic effects on retina. The diabetic patients are suffering from very difficult problems, and one of them is, of course, their eyes. Now, today I will try to bridge the gap between systemic diabetic management and ocular health. Our goal is to move beyond just checking the eye and understand the specific collaborative intervention which will save the vision. We will cover everything from the molecular mechanism driving damage to the modern standard of care treatments. We often say the eyes are the window to the soul, but clinically the retina is window into the systemic storm of diabetes. When you look at an image like this, now you are seeing here hemorrhages and exudates. They directly correlate with systemic drivers like HbA1c instability and hypertension or nephropathy. If the kidney is struggling, the retina is likely to. Now let's briefly look at why these problems are arising in diabetic patients. It's a cascade of molecular damage. The first step is hyperglycemia. That hyperglycemia is activating sorbitol pathways and it causes osmotic stresses. Secondly, the osmotic stress is becoming a reason for advanced glycogen end products accumulation. And finally, it activates proteinkinase G, and this one is causing our pericyte to lose. These cells are so important because they are structurally supporting the capillaries. Without pericytes, the vessels walls weaken, leak, and they cause all the problems that we will discuss today. Clinically, we divide the retinopathy in two main stages, non-proliferative and proliferative diabetic retinopathy. On the left side, you are seeing an example for NPDR. That one is the early stage of diabetes. And on the upper side you see microaneurysm, on the lower side dot plot hemorrhages. In this stage the patients are suffering from vision loss, but it's not that much significant, and the vessels are not growing abnormally, they are just leaking on this stage. On the right side you see PDR stage. That one is threatening vision very much, and the main problem here is neovascularization. It means the vessels are growing abnormally and they cause so many problems in diabetic patients. And one of them is preretinal hemorrhages, as you see on the lower side of the screen. While PDR is dramatic, the diabetic macular edema is the main vision loss in diabetic patients. It's a real vision thief in these kind of patients. What is it causing? Do you see that white circle on the screen? That one is macula, and it's affecting that part of the retina, and it causes swelling on the macula. When the macula is swollen, of course the vision is being affected, and the patients are not able to see that much good. And please look at that hard exudates on the above. These yellow waxy deposits, these are the lipid residues which behind from leaking vessels. If you will see any sign like that in direct ophthalmoscopic examination in your clinic, you should refer this patient to an ophthalmologist as soon as possible. We are not able to see the macular edema always by just direct ophthalmoscopy. Because of that, we are using optic coherence tomography. We are calling it OCT, and you can think of it as an optical biopsy. On the upper side, you see an example for a normal OCT, and it shows a nice smooth deep because it's a normal foveal contour. But on the lower side, you see an OCT which is belong to NPDR patients. Now, because of my not having pointer, I will just try to describe it to you. That those black cystic spaces are including fluid, and these are the main reason of diabetic macular edema, and it causes the vision loss in diabetic patients. Another very important method in our hand is fluorescein angiography. We use this test to understand the blood flow in the retina. On that dark space you are seeing on FFA image, this is a non-perfusion area. It means that part of the retina is starving for oxygen. And on the upper side you see a white bright spot. It's showing the active leakage. By the help of that sign, you can understand where the vascular competence has completely failed. This slide is very crucial for me. I want to describe it to you. That one is calling as early worsening phenomenon. Look at that two line, please. The red line is representing HbA1c in diabetic patients, and the blue line is representing the severity of diabetes. When the HbA1c drop rapidly, the severity of diabetes is peaking temporarily. It doesn't mean that you shouldn't control the diabetes or you shouldn't decrease the HbA1c. It means a rapid drop in HbA1c needs closer follow-up in diabetic patients, and you should refer these kind of patients to an ophthalmologist if you are planning to drop HbA1c rapidly. After understanding the molecular mechanism and diagnosis of the disease, now we will talk about the therapy. The treatment has undergone a huge paradigm shift in last couple of years in diabetic patients. In last years, in a very old time, we were generally applying laser, or in unresolved unclearing hemorrhages, we were doing surgeries for this kind of patients, and the result was not that much satisfying. But now with anti-VEGF injection, we are taking very good benefits. Now I want you to just look at the baseline OCT. It shows a massive swelling. After a few doses of anti-VEGF injection, the edema is completely resolved and the anatomy is completely restored. Of course, still we have laser and surgical therapies, but they become an advanced interventions anymore. On the left side of the screen, you see an example for PRP. By this application, we are sacrificing from peripheral vision to save the central part of the vision by reducing ischemic drive. On the right side, you see an illustration of retinal surgery. Of course, it's very easy to see it like that, but it's a very complicated surgery, and the results are not that much satisfying sometimes. That one is being reserved for advanced diabetic patients or long-standing non-clearing hemorrhages. There is a special group of patients that needs special consideration. They are pregnant patients. As you know, pregnancy accelerates the retinopathy progression independent of baseline diabetic control. This is why the diabetic patients monitoring should start from the first trimester, and they have to be followed until the postpartum period. Another important step of the management is screening. In type 1 diabetic patient, screening starts 5 years after diagnosis, because generally, 95% of type 1 diabetic patients are not producing any problem in their retina in first 5 years of this illness. But in type 2 diabetes, the screening should start at the time of the diagnosis, because you would never able to be sure about the certain time of the illness. And as I mentioned before, pregnancy needs a special care. The screening should start in first trimester in these patients. The next important decision is referring that patient to an ophthalmologist. When you should refer this patient, I try to create a traffic light system for screening and of course referration. The green line group contains asymptomatic patient who is suffering from diabetes. The annual screening will be very enough for this patient. And the second patient group is urgent patient who is creating rapid HbA1c drop or pregnancy. These patients should meet with an ophthalmologist in a few weeks. And the right light group contains urgent patient who has sudden vision loss or knee floaters or metamorphopsia. We have 4 critical steps in diabetic management. First of them, and the most important for me, is controlling the diabetes, because you should manage these patients systematically, and you should do collaboration with other branches. No need to be stubborn, and of course you should be very careful about rapid drops in HbA1c. Second step is screening, as I mentioned before. In type 1 patient, 5 years after diagnosis enough. In type 2 patient, at the time of diagnosis. And referration criteria depends on visual change in our patient's size. About the treatment, the last step, the most important and the gold standard therapy is anti-VEGF. While I am finishing my words, I want to emphasize that one again. Managing diabetic eye disease is a collaborative defense against blindness. Please don't leave your patient alone. Keep in touch with your ophthalmologist and don't let your patient to be blind. Thank you for your attention.